Hi everyone and welcome to the Greater Manchester Neuro-Rehab and Stroke webinar series. My name is Gemma Smith and I'm the Neuro-Rehab Network Facilitator. Today's webinar is on vision impairment in stroke neuro-rehab patients and we're joined by Dr. Claire Howard who's going to deliver on this today. For those of you that are not au fait with MS Teams live platform, you are all muted and your cameras are all turned off, although you still do have the ability to pose questions to the panel, and if you hover over your screen there is a question mark in a speech bubble and you can write in any questions here and we'll make sure that we ask them at the end of the session. If anybody does have Twitter, then please do tweet at GMNeuroRehab. And just a reminder, please do keep an eye out on our website for any upcoming webinars that are due over the next couple of months. And if you do want a certificate for today's session, then please do contact Lisa and she'll be happy to send these out. Right, I'm going to pass over to Dr. Howard now and she'll start with today's webinar on vision. Thank you.
Hi, my name is Claire Howard. Welcome to the webinar, and I'm going to be talking today about visual impairment after brain injury. So as a bit of an overview of the session, I'm being asked to cover screening for visual impairment, how and why we should screen for visual impairment after brain injury, referral pathways, how to manage different types of visual impairment, and the role of the orthoptist. So those are the things that we're going to cover in this session. So in terms of screening for visual impairment, the first question that we need to ask ourselves is, why bother? Why do we do screening? And there's several reasons for why screening for visual impairment is important. So the first one of those is around the incidence of visual impairment and how much this happens following a problem within the brain. So we don't have a lot of evidence and research around neuro conditions in general, but we do have a strong evidence base for stroke-related visual impairment. And unfortunately, neuro rehab as a whole seems a bit of a poor relation really in terms of research. And there's a lot of stones unturned, and we really need some more evidence base around different brain conditions and what the incidence of visual impairment is, and whether the visual problems that people have are different. Because the evidence base that we have is around stroke, I will refer to stroke quite a bit, and we will talk about stroke. But we've got to remember that the effects and the treatments are likely to be very similar. It doesn't really matter the cause of the visual impairment. What matters is how we actually manage that and deal with that. So we know from the IVIS study, which is looking at the incidence of visual impairment in stroke, that around about 60% of stroke survivors will have a new onset of visual impairment following their stroke. So, high numbers of people who have some form of visual impairment, which has obviously a sudden and devastating sort of impact. So the reason, and one of the reasons for why we see such a high prevalence is because of the visual pathway. So if we look at a cross-section of the brain, you can see that obviously the visual information comes in at the eyes, and then that information is relayed via the optic nerves to the very back of the brain, the occipital cortex. So it has to travel all the way through the brain. Right in the centre of the brain is the optic chiasm, and that's where there's some crossing over of information within the visual pathways. And so you can see that it's very easy for vision to be affected with a brain injury because there's so many parts of the brain that actually carry that vision information. So here's a diagram representation of the visual pathway. So if we're looking at an object, where that hits our retina at the back of our eye will depend where that information is relayed within the brain. So you can see here that different sides of our visual field are represented on different sides of the brain, and there is crossing of some of the fibres actually, so the nasal fibres actually cross over within the centre of the brain, which is the optic chiasm. So the chiasm is where the nasal fibres, which is in the information from the sort of inner visual area towards the nose, crosses over in the centre of the brain at the optic chiasm. Then that information is relayed through the lateral geniculate nucleus and back to the primary visual cortex, area V1, which is where we process all that visual information and make sense of it. The temporal fibres stay on the same side of the brain, and that's why we have things like homonymous hemianopia, which is where the right side of both eyes are affected or the left side of both eyes are affected because of this crossover at the optic chiasm. So another reason why screening is important, it's really important that we know if someone has a visual impairment because of the impact that that has. I say if you're born with a visual impairment, then there's a different process that people sort of go through. Whereas if this visual impairment happens as a sudden event, like happens with a brain injury, the impact can be quite, significant and devastating for the person and their family. So it has an impact on how they navigate their environment, all activities of daily living, washing, dressing, all functions that patient has. Reading and writing can be severely affected if your vision is affected. Reading involves eye movements as well as our clarity of vision, as well as our peripheral vision. And it affects rehabilitation outcomes in general. We know from some of the research that we've done that patients with visual impairment have poorer stroke rehabilitation outcomes, and that's likely to be the same for neuro-rehab conditions. In terms of other significant impacts, it's bound to impact somebody in their return to work, and people are much less likely to be able to return to driving if they've got a visual impairment. All of these things added together are going to impact on a person's mood. So if we look at the overall consequences of visual impairment as a whole, and these figures come from the World Health Organization, so if someone has a visual impairment caused by a brain injury, then they are 3 times more likely to be unemployed. That's quite bleak statistics really, but they're 3 times more likely to be involved in a motor vehicle collision, so knocked over, crossing the road, that sort of thing. 3 times more likely to suffer from depression and anxiety disorders, and twice as likely to have a fall when walking as somebody who doesn't have a visual impairment. So, we need to consider all of these factors, that if we don't identify that visual impairment and we don't then refer for appropriate management, these are the sorts of impacts that they're going to have within the everyday life. So this is what, this used to be common practice within the UK. We devised, the British and Irish Orthoptic Society devised a referral form, and we asked for the stroke and neuro teams to actually refer patients to us based on patient reported symptoms and signs. And this was reliant on the patient telling the clinician about symptoms that they had, such as double vision or blurred vision or visual field loss, or the clinician noticing signs like the eye was turning or a droopy eyelid or wobbly eyes, nystagmus. And so this was how patients were referred into the orthoptic service, and we were getting quite small numbers of patients from stroke services and neuro rehab services in terms of the signs and symptoms that were being recognised and referred into us and into our services. So, what's wrong with that? You might ask, but there's a very low sensitivity and specificity for referral forms when we're relying on the patient telling us what their symptoms are. There's a good detection rate for signs, so if someone's got a droopy eyelid or their eyes pointing in the wrong direction, that's quite obvious to the clinician, and those people were referred straight away. And I think that goes without saying that if somebody looks very different or they're really complaining about their eyes, then they're likely to access services without the need for screening. The issue lies around patients who don't report symptoms. And it might be that they don't report symptoms because they're unable to report symptoms because of communication difficulties or cognitive difficulties, Or it might just be that they don't recognise those symptoms, they don't have any symptoms, and again that's quite common following a brain injury, that somebody has, say, a visual field loss, or you would expect them to report that, but they don't notice the symptoms, they're not aware of them. There was an issue around education and training for the multidisciplinary team. We all know that the neuro-rehab MDTs tend to change, have staff on rotation, and if we do provide training in visual impairment detection for the MDT, it's likely that the staff will change, and you've got untrained staff then teaching the new staff that come in, and it's a little bit like Chinese whispers, the information gets diluted over time. So we needed to do something differently. We needed to improve our vision screening services, but we needed something that didn't require lots of training and updated training, and something that could be accessible to all patients without having to rely on patients telling us that they had a problem. So this is where the visa screening tool was developed. Originally there was a pilot study that happened for this, and the pilot study took place in some hospitals across Greater Manchester, one of those being Salford Royal, and we tested the visa screening tool to see whether it was an accurate screening tool to use. It showed real promise when we compared the results of untrained eye people, occupational therapists, physios, and therapy assistants, so people who were not trained to assess eyes, against an orthoptic assessment, so the visa tool against orthoptics. And it showed to be actually very promising, so went to a full validation study and was validated a couple of years ago now and made freely available for people to use. So it was developed by the University of Liverpool at the Vision Research Unit, and you can get access to the tool free of charge on the Vision Research website. All we ask is that you fill in a licence so that we know which NHS trust it's been used in, and then you can download it as many times as you like and print off all of the resources and tools that you need. So this is the full validation paper, if anyone's interested in more details, and it was published in BMJ Open. And it shows that the tool is very sensitive and specific for detecting visual impairment, and the whole remit of the tool is that it doesn't involve any specific dedicated training, that you can pick the tool up and use it. So there is a paper-based version and an app-based version, and both are freely available. The app-based version is currently available on an iPad, but there is an Android version currently in development, and that should be available in about the next 2 to 3 weeks. So this is what the visa tool looks like. The paper-based version has full instructions and guidance for use. The app has those instructions embedded within the app and has a visual field test actually on the app, and an inattention test that the patients do on the screen. On the website there is also a demonstration video, which is demonstrations of an orthoptist actually carrying out the screen to show you that, if you feel that the guidance isn't enough, to show you and actually demonstrate how to do the visual fields, how to do the eye movement testing, how to do the visual acuity testing. You might recognise the orthoptist that's actually doing those tests on that video, because that's actually myself doing those, but say it's still worth a watch regardless. So this is the University of Liverpool Vision Research Unit, who work very closely with us at Salford Royal Hospital, where I work, in terms of recruiting patients to these really important research studies. And I really urge anybody who can to get involved in these research studies, and I think anybody that has been involved will be able to see how what they've done has actually translated into clinical tests, And as a research clinician, I think that's really nice to be able to see that, to actually this isn't just about producing papers and going talking at conferences. This is about producing tests that are meaningful for patients. So thanks to all that got involved with testing the visa tool. We should be really proud of that. That is now available for people to use in everyday practice. So I wanted to tell you a little bit about the PAVE tool and the PAVE study, which was another part of the screening process. So it was recognised quite early on that actually paramedics could do a shortened version of the screen in the ambulance when the patient's on the way to hospital, or the decisions need to be made about which hospital to transfer the patient to. So working in collaboration with the North West Ambulance Service, the PAVE study, the Paramedic Visual Evaluation study, was developed. And this resulted in the PAVE VFast tool being released. And again, this is freely available for paramedics. And the idea of this is it's a very quick checklist in the back of an ambulance with quick guidance on how to do the individual tests, in terms of, is there something there to do with the vision? And this just helps that initial diagnosis. Could this be a stroke? Could this be something that we need to worry about? And do we need to be thinking about getting somebody to the hyperacute stroke centre? So the PAVE tool, like I said, is freely available, and again, we'd really like to thank the North West Ambulance Service for contributing to this really important research. So in terms of the current referral pathways, this is a little bit more difficult for me to answer with any sort of clarity, because obviously we're all from different hospitals across Greater Manchester, and there are going to be different referral pathways depending on where you are and where you work. But I just wanted to go over some general principles. The first thing, the gold standard, would be that all patients are screened by an orthoptist, and that really would be what we would want. We would want to see that anybody with a brain injury is screened for visual impairment by an orthoptist in a timely manner, ideally as soon as possible. In reality, we know that that's very variable, and not many services have access to that sort of service across Greater Manchester. We are currently looking at streamlining commissioning arrangements and hopefully looking at getting some more equitable services for Greater Manchester, so that we've all got access to the same service and not got the same unmet need and health inequalities that we've currently got. But as it stands, because we don't have stroke specialist orthoptists across the pathway, what we could look towards is using a validated screen for these patients. So the idea would be that an orthoptist would screen all these patients, with the screen being used as a mop-up for those who maybe come in at the weekend or haven't had access to an orthoptist. But I think in reality at the moment we're going to be looking at a validated screen such as the visa tool for all patients. So I would urge, if you're not currently screening your neuro-rehab and stroke cohorts for visual impairment, that you should consider downloading the visa tool and using that within your teams. So if somebody fails that vision screen, so a vision problem has been identified, I would strongly urge that we need to be referring those patients into orthoptics. And that obviously has to follow, at the moment, has to follow the local pathways, and it's very inconsistent again across Greater Manchester. Some hospitals have really good inpatient services and access to neuro specialist services, which would be the gold standard, and that's lacking in some areas, and in some areas I know that that referral pathway is not very clear. But every hospital trust has access to orthoptists and can refer into orthoptists. If that has to be done via the GP, that's not ideal, but at least it's a way of getting those patients in. And I would urge that even if you don't have neurospecialist orthoptic services at the moment within your services, that we should be referring these patients into orthoptics and getting that baseline assessment for them and management for them. I've put a bit in here about the British and Irish Orthoptic Society care pathway, because that's the care pathway that orthoptists are given and handed down from our professional body. So this is the pathway that we should follow for stroke and neuro patients. And this gives us our assessment timelines and documentation timelines and what we should be doing with patients with different conditions. And we should be following that care pathway where possible. And I think really we should be holding the orthoptic departments to account to say, well, your professional body care pathway says that if someone has a visual field loss following a brain injury, that you should be offering them an appointment within 4 weeks to do a driving assessment if they're a car driver. And if they're not doing that, they're not conforming to their care pathways, and we should really be we should be tackling that. And there is a bigger picture to this, and hopefully the situation will change in the future. But what I would strongly urge is that as many people as possible are screened and referred to orthoptics as per your local guidelines. And I'm happy to chat to anybody on an individual basis about that. So this is the BIOS stroke and neuro rehab care pathway. So this is when someone's been screened and found to have a particular problem. This offers guidance to the orthoptist as to what we should be doing in terms of follow-up and what we should be doing in terms of letters and written information to be given. There's also a driving pathway that goes along with this, but we've got to remember the driving pathway is specific to stroke. And the reason being is that obviously all different neuro conditions will have different driving restrictions, and we've got to remember. So for example, someone who's had a stroke can't drive for 4 weeks, can't drive a car for 4 weeks, but someone who has had, say surgery to remove a brain tumour will, more than likely not be able to drive for 12 months. And someone who's had a seizure associated with their brain injury, again, will more than likely not be able to drive for 12 months. So it's difficult to make a generic driving pathway, but in terms of this care pathway, this is certainly a generic pathway. So if we look at there's also been a stroke and vision care pathway developed, and this was developed again in collaboration with the University of Liverpool, and this was done using consensus methodology. So that basically means that a group of experts were in the room. So you've got opticians and orthoptists and eye clinic liaison officers and patients, different members of the multidisciplinary team, looking at what should happen with stroke patients, where those patients come into the pathway, at what point they should be referred on to different services, and then agreement was made on what the pathway should look like as a gold standard. And this pathway was released and published. Again, we've got to remember that this is specific to stroke. So if we look a little bit about the management of visual impairment and what sorts of things can we actually do to help these patients. So the first thing that we're going to talk about is impaired central vision, and by central vision we mean visual acuity. So that's our ability to read down the letter chart. So is our vision blurred, or what sort of clearness of vision have we got? So if somebody's got reduced central vision, there might be many reasons for that. One of those reasons might be that that somebody's just not got the right glasses. So just because someone's had a brain injury doesn't necessarily mean that any vision loss is associated with that brain injury. They might have an underlying vision condition. They might have lost the glasses or broken the glasses when the brain injury occurred. They might, they might just not have access to the glasses in hospital. So referring for a refraction, which is a glasses test, can be really useful, or considering the use of low vision aids, which is through the low vision aids at the local opticians, with things like magnifiers, that can really help. The Specsavers do a home call service, so if you've got patients who really struggle to get out to an optician, you can give them the contact details, which again, if you Google Specsavers home call, they would actually go out to a patient's home and do an NHS sight test for that patient and provide glasses. The ophthalmology service comes in if someone's got an underlying eye condition or something you suspect that there's something with the eyes themselves. Obviously, the majority of people that we see with visual impairment after a brain injury is because the brain is the problem and not the eyes. But sometimes we do see eye conditions and can refer to an ophthalmologist as an option. Coloured overlays can really help because a lot of people after stroke or brain injury can really experience a lot of glare from the page. So if you've got a white page, they can get glare from that. So putting a coloured filter over the page so it's not white anymore and there's less glare can really help. We often find that yellow is the colour that patients choose. Typoscopes are basically black pieces of card with pieces cut out so that rather than being overloaded with visual information, people have just got one section of text to read, and again that can really help. And verbal advice can be really powerful, and we shouldn't underestimate that. So giving people advice on what's happening with your vision. Other things that can be helpful are teaching people compensation strategies that people who after brain injury might not automatically use these compensation strategies when they've got poor vision. Things like putting their head into a different position to make the best of their vision, or it might be that if you've lost your central vision, you need to sort of view things slightly off centre, so eccentric viewing of objects, and actually teaching people about those different positions might be necessary following a brain injury. Another useful tip for people with reduced vision might be to adapt their tablets or smartphones in terms of the accessibility settings. And again, University of Liverpool have developed a resource with some really good advice in terms of how to actually change those accessibility features for Android and for Apple. So you can download that free of charge off the website. So let's now talk about eye movement disorders. So by eye movements, we mean that there's something isn't right with how the eyes move. They're either not, working and moving in the same direction, or they're not. The eyes are constantly moving and wobbling, like with nystagmus. And generally, when somebody has an eye movement problem, this causes the symptom of double vision. So you see two, if your eyes are pointing in different directions, you see two different images. So the treatment, the short-term treatment for that, and the most effective sort of easy, quick treatment for that would be to put a patch over a patient. So to patch one eye. This would eliminate the second image and get rid of the double vision. But there's several drawbacks with patches. One might be that they're not easy to wear, they're not particularly comfortable to wear, especially somebody who's just maybe had some brain surgery and has quite tenderness around the head and scalp. To wear a patch with string around that is not ideal. But also it reduces your peripheral vision on that side. So if you've got a patch over, say, the right eye, you're not going to be able to see what's approaching to the right. There is a much better solution, which is a prism, but that has to be measured and prescribed quite specifically by an orthoptist. And I would really urge you to refer anybody with double vision to an orthoptist as soon as you can. Ideally, if they're still an inpatient, to get them seen as an inpatient. And if I get a referral for somebody with double vision, I would see this as a very top priority, and they would be first on my list to be seen, because double vision is, it's very disabling, it's very disorientating, it really affects a person's ability to do anything in everyday life, and it's actually very quick and easy for an orthoptist to fix. Most double vision can be fixed with a prism, and the prism, it bends the light that goes into the eye and fools the brain into thinking that it's in a different position. So we can fix double vision if it's horizontal or vertical. If there's a bit of a tilt or a twist to the double vision, that's more difficult or impossible to fix. But the majority of double vision can be fixed quite easily with a prism, and I would urge that you get those referred in. So let's now have a look at visual field loss or loss of peripheral vision. So for visual field loss, it can be very empowering for patients to actually get sort of verbal advice and to be told exactly what's going on with the vision and what's happening. That in itself can really help a patient for them to understand the concept of what's happening. Again, teaching somebody to move their head into a position to get the best out of their vision can be really useful, because not everybody does that automatically. And scanning exercises are sort of treatment of choice, and we'll talk a little bit more about that. Reading strategies can really help in terms of putting markers at the beginning and the end of lines and making sure that people scan. Anybody with a right-sided visual field loss is much more likely to have problems reading, because we read from left to right. So if you have a right-sided visual field loss, you struggle to find the next word and to follow the print. If you have a left-sided defect, you can read the words perfectly, but then you can't usually find the next line when you jump to the next line of print. So things like typoscopes can really help in terms of blocking out the amount of print, or line guides, which is just basically a piece of coloured card cut out so that the patient can hold it against the start and end of the line. Peli prisms are prisms that extend the visual field, and they've been used for a number of years to try and give patients a better quality of life by extending the visual field. We have done some research into different forms of treatment for visual field loss, and the only treatment that came out favourably in terms of impact on quality of life was scanning exercises, and they're actually showing some real promise. Peli prisms didn't show any real improvement in terms of quality of life, but did actually cause quite a few distortions, double vision, headaches and side effects for patients. So we don't use those as a matter of course anymore. So a Cochrane systematic review has been done looking at interventions for visual field loss and what evidence there is around that. So a Cochrane systematic review looks at high quality randomised control trials in a particular area, and this one specifically for visual field loss was recently updated, and the overall evidence shows that compensatory scanning training might improve quality of life following this visual field loss, and that actually that more evidence is needed within that area to build an evidence base and more information. There is insufficient evidence regarding restitutive therapy, and restitutive therapy is therapy where the visual field is stimulated, and the purpose of that is to restore the visual field. So there's no real evidence to say that we can restore the visual field area. And there's insufficient evidence to support the use of Peli prisms. In fact, while they didn't improve quality of life when using prisms, they also caused a range of adverse effects, including double vision and headaches. So the real sort of treatment of interest with visual field loss at the moment is compensatory scanning training. So the University of Liverpool, the Vision Research Unit, have developed some vision scanning activity books, visual impairment activity books, and this is a range of exercises that promote scanning to the left or right that have been particularly developed for people with visual impairment. And this is a range of mazes, word searches, crosswords, colouring in, and puzzles that patients can do. And the whole idea behind this is because, we've all spent time scrabbling around on the ward trying to find a word search for a patient, and the idea was that we put all of those resources together into a book. And again, these are freely downloadable off the website, and you can print them off to use within your rehab units or outpatient settings. There was such a positive response to these activity books, and they've been used a lot of times. So we've actually been asked to develop a second book with different resources for patients who've completed the first book. So there's now an activity book 2 available as well. I wanted to tell you a little bit about the SEARCH trial. So the SEARCH trial is a study that started recruiting in May, so literally just a few weeks ago. And Salford is the lead site for this, but this is going to be recruiting across 25 sites across the UK. We recruited the first patient at Salford at the beginning of May. And this is looking at scanning eye training. So this is providing that evidence that was lacking in the Cochrane systematic review. So this is specific to stroke, not other neuro conditions, but this is asking for patients with hemianopia to take part, and they'll be randomised to receive intensive rehabilitation therapy in form of exercises. 50% will receive visual scanning training, and 50% will receive a sham training, which is actually a training that was developed for eye movement disorders, and the patients won't know which training they've been given. They'll be given training every day, and the outcomes in terms of quality of life and visual fields will be compared at the end of that. So if anyone's got any patients that they think might be suitable for this, what we're asking for is for patients with post-stroke hemianopias, who are more than 4 weeks but less than 6 months post-stroke, and we can't take anybody who has already had a lot of scanning training. So what we're asking is that if you think that there's people that might be eligible, that might want to take part, that you don't do lots of scanning training with them, that you just let us know. And we have been asking people on the wards to, don't automatically start the scanning training straight away. Let's see if they're suitable for the SEARCH trial, because this will give us the evidence that we need for the future. So let's look at visual perception. So by visual perception, we mean there's a disorder in the way that we process the visual information and we perceive the visual information. That might be a visual inattention, which is the most common visual perception disorder, but it might be an inability to recognise faces, or people might see different sizes of objects and different colours to what you would expect to see. So it's a problem with the way our brain makes sense of our vision. And it can be really disturbing for patients, and reassurance and explanation can be, the most important aspect of treatment for this. And again, compensation strategies are not always done automatically, so it's something to consider, that making sure that we recognise these visual perception problems. So in terms of visual inattention, the treatment of choice would be to stimulate the vision on the affected side and promote visual scanning on that side. There are quite a lot of apps and vision therapy apps, and the British and Irish Orthoptic Society have produced a leaflet which actually lists all of those apps that are available for visual field loss and visual inattention. Typoscopes again can help, because they really promote a person being able to look at a specific area of text. And bed position should be considered if someone's an inpatient. If someone's got visual inattention and the only thing that's interesting on their inattentive side is, the only thing that's there is a wall, that's not going to promote them to turn their head. So we need to think about, what's interesting on the ward, where do people approach, where do people come in, and can we put that on the inattentive side to really promote visual scanning to that area. Visual hallucinations are always worth mentioning. Often people who lose vision through a brain injury will have some form of visual hallucinations. They are underreported because people are worried that they might be having, some sort of psychological episode where they are, experiencing these hallucinations that are not real, and they don't report them. So we need to ask about them and reassure that they're actually a normal part and parcel of visual impairment after brain injury. I often describe them as the brain trying to fill in the gaps. There is a charity called Esme's Umbrella who have some great resources for visual hallucinations, which is also called Charles Bonnet syndrome. So I wanted to tell you a little bit about the role of the orthoptist, and the main question that I get asked, probably the question that I get asked the most in general, is what's the difference between an orthoptist and an optometrist and an ophthalmologist, and what's all the different professions. So an ophthalmologist is the eye doctor. They're the person who will, they're medically trained and then specialise in eyes. They very much look at diseases and pathology of the eye itself and the retina and the optic nerve, the very start of the visual pathway. And they will look at the eye itself and diseases of the eye. An optometrist will look at the focus of the eye and how the eye focuses and whether lenses will actually help with that, and in terms of the actual vision. An orthoptist looks more at the vision and the functional vision, so how our vision develops, how our eyes move, and how we actually use our vision in everyday life. So that might be to do with how the brain controls the vision rather than the eyes themselves. And an eye clinic liaison officer, I've just put on there just in case anybody's never heard of one of those, but these are people who support the eye clinic. So the eye clinic liaison officers are there within eye clinics to support patients through their visual impairment journey. They might provide information, they might provide support with benefits, with getting sort of access to equipment, symbol canes, so white folded up canes, to make everybody aware that they've got a vision problem. So there's lots of resources available. The British and Irish Orthoptic Society have a range of patient information leaflets on the care pathways, lots of information about driving, and I would urge anybody who doesn't have these resources and hasn't had a look to go and have a look at the Orthoptic website. So this is the leaflets that are available. There's visual inattention, visual fields, visual perception, eye movements, reduced vision. There's all the web-based therapies and apps. And there's a new leaflet that's just been developed over the last 12 months on driving and vision defects. We've talked about the Vision Research Unit resources, but there's a whole range of resources available free of charge, and there's some that are available for patients and some that are available for healthcare professionals. All of the patient resources are available as audio files on the website so that they're accessible for those with visual impairments. So this is the website itself, and you can see here that there's all sorts of, there's like health promotion guides, there's leaflets on different eye conditions like say dry eyes, looking after people's glasses, looking after people's prisms. So there's a whole range of resources for healthcare professionals to actually be able to use. But I think the patient resources are on there as well as all the visa and paid tools and videos. If anyone's interested in reading further about all the research that we've done, a lot of the papers and the research are actually here to save you going looking for them. They're open access and you can actually get the links to them on this website. So that really is a bit of a whistle-stop tour of the stroke and neuro rehab, visual impairment, how to manage them, how to sort of refer patients in. I'm happy to ask any questions, and so if anyone's got anything specific and they want to ask me now, that's great. I'm happy to have any discussions about any sort of service issues or issues that people have come across. And just as a last note, thanks very much to the network to inviting me to do this webinar, and we urge you to think not fast in terms of stroke. We urge people to think VFast and always consider that vision can be affected and is often missed, and that screening is really important. So thanks very much for listening, and we'll have a look now at if anyone's got any questions. I'd be happy to answer them if I can. Thanks very much for your time.
Thanks, Claire, for delivering a really informative talk, and I think you've provided everyone with lots of resources to go away and think about and download. Just a reminder to everybody that there is a question mark in a speech bubble, so if you do have any questions for Claire, please do put it in the box and we'll ask them for you. Also, just a reminder, we're going to try something a little bit different today. So rather than send out a evaluation survey, we're going to ask that before you leave today in this Q&A box, if you just rate today's session from 1 to 5, 1 being poor, 5 being excellent, and just put a brief comment next to it, and we'll see if we get some good feedback that way, if that's okay. So first question just come through, Claire, not sure who it's from, just saying, I was wondering whether you would prescribe a prism for double vision early following a stroke, or whether you would expect changes to occur over time and therefore wait for further recovery before advising on the use of a prism.
Yeah, that's a really good question. I mean, in an ideal situation, you would want to prescribe that prism as soon as possible, and you know there's no clinical reason to wait. Admittedly, that the situation might change. So in an ideal world, if you've got good access to orthoptics, then the sooner that prism goes on, the better, because that person's going to be living with double vision or with an eye patch on if we don't prescribe that prism. In reality, not all units have good access to orthoptic services quickly, so it's probably not going to happen. But if you do have that access, I would say the sooner that prism goes on, the better. But it's likely to need continual review, because as that patient does change, if they recover, the prism will be the wrong strength, and so it will need changing. But if you've got good access, absolutely, that prism needs to go on as soon as possible and be reviewed on a regular basis.
Thanks, Claire. Another one here from Susan, not sure where Susan works, but it says, I find it very difficult dealing with patients who are very unwell after their stroke. I'm quite new to working within the stroke patients. Any particular advice? I do ask for help, but staff not always available. I think that's possibly in relation to doing visual assessments with an unwell stroke patient.
Yeah, and in reality, if somebody is very unwell, it really is about looking at the priorities for that patient at that particular time. And if somebody's quite medically unwell, it's not always appropriate to go and do a vision screen or a vision assessment. And really, it's about just remembering that you don't have to do all of the screen in one go, that you could go and do what you can do with that patient and then go back and do other bits on other days. And that it's not necessarily a checklist where you have to work through the whole of the screen on one particular day. It might be that you go and look at someone's vision on the first day, and then you look at their eye movements on the day after, and that they can only open their eyes for a short period of time. And again, looking at priorities, if someone's got double vision, that's the thing that we would need to deal with first and make that patient comfortable, and then go back and always think to go back and revisit the screen. And it's one of the areas that we find is often missed, is often why the vision problems are missed, that if someone is acutely unwell and the screen isn't done within the usual time frames, it's then somebody remembering to go back and do the screen at a later stage. So really just revisiting that when the patient is able.
Yep. Another question here, is there a preference over which eye to patch with someone with a nystagmus, and how long should they wear the eye patch for?
Yeah, I mean, for eye patches for any condition, not just specifically for nystagmus, whether it's for nystagmus or whether it's for double vision, it doesn't matter which eye you cover from a clinical point of view. Ideally, you want the one that causes the most relief to the patient. And if the patient has considerable relief from having a patch on, that can be left on all day. There are a lot of myths flying around on the wards that say that you should only patch for a short period of time because you might make the eye underneath lazy, or that you need to swap the patch between the eyes because you'll make the eye lazy. In reality, once somebody's over the age of sort of 9, 10, you're not gonna make someone's eye lazy. And if you patch the eye permanently, as soon as you take the patch off, the eye will be able to see again.
So whatever gives the patient relief, if the patient isn't able to communicate how you feel they are in function and how they seem to act with the patch on, whichever eye seems to be the best fit, put it on that one. I mean, if you've got one eye that seems to be moving very abnormally and looks very different, that would be your first choice for patching. But we've got to remember that somebody might have long-standing poor vision in an eye that's been there for a long time, and if you patch the eye with the good vision, then they're not going to do very well. So, you know, try each eye, trial and error, experiment if you've not got access to an orthoptist.
Thank you. Next one, why is VFast not promoted as much as FAST?
Good question. I mean, there's lots of different acronyms on the FAST campaign, and you know, we have approached Public Health England around VFast, and they didn't want to take it up in terms of that would dilute the message from FAST, because obviously FAST is a national campaign and there's a message there, and you know, there is a danger that you would dilute the message. And you know, there's also BFast, which is BE, which is balance and eyes, which again looks at those sort of posterior sort of symptoms that are often missed. And you know, it's that real sort of fine balance between promoting, you know, as many sort of problems as you can through stroke, but actually thinking about the bigger picture. And you know, I feel it's really important, obviously, that we think about vision, and I'm sure a lot of people agree with that. But Public Health England have, you know, put a lot of resources into the FAST campaign, and that at the moment is the way that's going to stay.
Yeah, the question here from Linda. Do you work with the sensory team? I'm not sure we refer to this service enough.
Yeah, I mean, the sensory teams, again, this is very local depending on the areas that you work in, but it's really important that we work closely with the sensory support teams to support that person when they've gone home from hospital. And certainly in our area in Salford, if we register somebody as sight impaired, that then triggers an automatic referral to the sensory support teams. It can take a while for that to really come into action. So what you might find is that you register someone as sight impaired, you do a referral to sensory support, and in reality it can take a couple of months for that process to happen. So the link between those two services is your local eye clinic liaison officer, and I would urge everybody to find out what services are available locally, and it depends what area you're in as to what you've got locally through social services. Eye clinic liaison officers will bridge that gap between someone who's waiting for sensory support and they will, you know, work with a patient and support them before their registration actually comes through. So it's really key that we engage with our local sensory support teams.
Thank you. Another one here from an anonymous. For the search trial, if we have suitable patients, how do we refer, and would we just send an email, or is there a specific referral route?
Yeah, I mean, that's a bit of a tricky one because I'm not sure what area that person's in. So if that was a Salford patient or, you know, a Greater Manchester resident and somebody that's local, they would have to basically travel every 6 weeks for the first 3 months of the study to the local hospital to have assessments. So if it was a Salford or a Greater Manchester patient, absolutely email me and I will pick that patient up. If this is somebody from outside of the Greater Manchester area, what I would do is urge that people contact Professor Fiona Rowe, who's from the University of Liverpool, and all her details are on the Vision Research website, to see where their local centre is that's recruiting, because there's 25 hospitals across the UK that are recruiting to this study. But yeah, if this is a Greater Manchester patient, absolutely, you know, send me an email on a secure email address, an nhs.net email address, and I can pick that patient up, regardless of whether they're a Salford resident. It doesn't matter. If they're willing to come, then we can recruit them to the study.
Great, thank you. What is the current treatment advice for visual neglect? I am aware that for visual inattention, it is important to provide stimuli to the patient on the affected side to promote visual attention, but is this the same for a neglect?
Yeah, I mean, if you've got an isolated neglect, then really it's about that stimulation to the neglected side, and that would be the same if you've got someone who's got a neglect and a heminopia on top, because they're not going to compensate for their visual field loss and turn the head. So really, it's about as much stimulation as you can to the affected side, the scanning exercises, and there is a British and Irish Orthoptic Society leaflet, patient information leaflet specifically on visual neglect and the therapies that we recommend. And there's also a leaflet on web-based therapies for visual neglect, and that is around if someone does have IT access, a phone, an iPad or a computer, that's about pointing them in the direction of some very sort of targeted visual neglect exercises. So I would urge people looking for more specifics on that to look at those resources.
Great. I'm conscious of time, so I'm going to try and whistle through as many as I can in the last few minutes. What is the best way for someone to access an assessment if their vision hasn't been picked up as an inpatient and they are not seeing any clinicians for any other symptoms? Would they need to speak to their GP?
Yeah, I mean, if community rehab teams are still involved, I would say that would be the first point of call for that patient. But failing that, a GP could refer directly into an orthoptic service. Yes.
Great. Another one here. Do you have any guidance on how to differentiate between a hemianopia and a visual inattention? Should we routinely refer onwards to specialists for those we suspect a visual inattention?
Yes, I mean, to be honest, distinguishing between inattention and heminopia is pretty much sort of a topic on its own, and it's something again that I get asked about quite a lot. And certainly we can plan an event for the future where we specifically look at distinguishing between those two conditions. And I think there's not enough time for me to fully answer that question right now, but if that person wants to email me as well and ask for some specific advice, then that would be fine.
Great. Another one, do we download the app for the visa off the website? Just checked Apple iStore and can't find it.
Yeah, I did exactly the same thing. The easiest thing to do is to go on the website, click on the link, and it automatically takes you to the app. It's not especially easy to find on the Apple iStore, but it is there. I've downloaded it onto my iPad in the last few days, so it's the link is the easiest way.
With regards to the search referrals, just said, please could you provide your nhs.net secure email address so that they could send any potential referrals? Yeah, not a problem. We'll put that into the chat here for everybody, and make sure we send it out in the email with the recording so that everybody's got it.
Yeah.
Is there any techniques that would be useful for low-level PDOC patients?
Again, if somebody's very low level and they're really sort of only just opening their eyes, the main assessments that you could do would be to look at their level of attention and their sort of level of observation around the room. So it would be more about observing the reactions of that patient than it would about a formal assessment. It might be that that you've got a couple of people in the room and see if the person reacts to either side. Looking at whether there's a blink reflex, so we automatically blink as objects approach us if we've got useful vision, and if the person doesn't blink to visual threat, then it's likely that there's no visual responses. Looking at pupil reactions and whether the pupils react to light and dark, and whether the person seems to react to light and dark can be really useful. Again, that's probably another session on its own in terms of looking at, rather than a formal visual assessment, a more functional visual assessment, and that's something that we could potentially look at to cover in a further session.
Thanks, Claire. And I think we've got through all the questions just on time.
Oh, that was good.
Thank you everybody for attending and for posing your questions. Obviously, with the amount of questions that come through, it's obviously been a really useful talk, and from looking at some of the feedback already, you know, it's really positive, so that's great. Just want to thank Claire again for attending, and equally, before you do leave, if everybody could just give us a quick rating from 1 to 5, 1 being poor, 5 being excellent, with just a quick comment of how you found the session, that would be really great. Right, that's it. We'll finish for today, and we'll send the recording out to you shortly via email, and we'll include Claire's nhs.net email in that as well. Thank you all.
Thanks everyone.